Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 274 of the podcast. It's February 1st, 2017. My guest today is Jay Arthur, author of the book Lean Six Sigma for Hospitals, Improving Patient Safety, Patient Flow, and the Bottom Line, second edition. Now, to me, Lean Sigma is often a controversial topic. Not because there's anything wrong with Six Sigma. Six Sigma methods can be very compatible with a lean culture. But Lean Sigma books and trainers, including Jay, paint a picture that says lean is only about speed or efficiency and that Six Sigma is the method to improve quality. In Jay's otherwise excellent book, he unfortunately says that lean is about addressing all of the types of waste except for the waste of defects, and that Six Sigma is used to address defects. I find that just sort of silly because the types of waste come from lean and the Toyota production system. Lean is, of course, a quality method. It's about flow and quality. They go hand in hand. Lean methods and mindsets can very directly improve quality, as can Six Sigma. So I don't disagree that Lean and Six Sigma can be compatible. I just don't like the picture that says Lean is only about speed or cost or efficiency. So I disagree with Jay on that point. I challenge him about that a bit in the podcast, but there are many good points in his book about improving safety and flow, not overcomplicating Lean or Six Sigma. And I agree the goal is to get results and develop people at the same time. So if you'd like to see more about the book, some videos with Jay, he does have a lot of free material online. You can find links to all of that at leanblog.org/274. Thanks for listening. Jay, hi. Thank you for being a guest and joining us on the podcast today.
Hey, thanks for having me on.
Start off, just kind of the basics. If you can introduce yourself for the listeners and tell everyone a little bit about your career and in particular, how did you first get involved in process improvement, quality, whatever terms you would use?
Sure. Well, I'm Jay Arthur, author of Lean Six Sigma for Hospitals and the QI Macros for Excel, which is a tool to do all the charts and graphs you need. And I got started, I spent 21 years in the phone company building software and everything from mainframes to mini computers to microcomputers. And then in 1990, our VP of operations, IT operations, said, I'm going to get into this total quality improvement game, and hired Florida Power and Light to come in and train us in how to do TQM. And then out of that, I became a team leader and an instructor, and we started lots of teams. And after about a year, we discovered that out of 100 teams, only about 3 had succeeded. I said, wait, this was some of the best training I've ever had. What is wrong? And so I started to try and figure that out. And over the next 5 years, I worked in various locations on various projects. But in the last couple of years, I got involved with finance, and we started looking at postage costs had gone up $20 million. Well, we did a little analysis and found out that, it was because we were adding new telephone companies onto our bill, and that was increasing postage costs. How do we fix that? And so we led a team that saved $20 million in postage and $16 million in adjustments. And then in 1995, our leadership team said, wait, we're not getting any return out of investment out of this total quality department. So they shut us all down. The VP of finance called me up and said, hey, do you want to work for me? And I said, well, I think I want to go out on my own. So in December of 1995, I left, went out on my own, started doing consult. And then got into the whole game, and because I was a geek, I started figuring out how to make Excel draw the charts I needed to be able to do process improvement. So that's kind of the speed story.
Well, sure, and we can kind of delve a little deeper into some of that. You mentioned Florida Power and Light. Part of my geekiness, kind of early exposure in my career to Dr. Deming. Florida Power and Light was pretty famous for winning the Deming Prize, which is probably why that was the credential that led to them being brought in to work with you.
Mm-hmm. They were still applying.
Oh, okay.
They hadn't won it. He got them in 89. I think they won in 90.
Okay. But what you mentioned there, a couple of things you mentioned, I mean, it sounds, I think, very familiar, here in the year 2016, end of the year when we're talking, somebody canceling a TQM program because they weren't seeing an ROI from it. I've got a book on my shelf. I think it was called Why TQM Failed and What You Can Do About It. And that was a fairly common problem. I mean, we see similar things, happening with lean. I see hospital systems canceling, getting rid of their quote unquote lean department, which maybe that's part of the problem if lean is a department. But what are some of your thoughts around, that failure rate? What went wrong? Are there common themes that are still happening today?
I saw Michael George from the George Group talk about, after he left the group, one company spent $4 million with his company and had no bottom line improvement. Wait, how is that possible? I'm sorry.
I mean, you'd think most organizations have so much low-hanging fruit.
The problem is everybody thinks that, but all the low-hanging fruit has been plucked. I call it invisible low-hanging fruit. Nobody knows how to find invisible low-hanging fruit in an organization because it's buried in data sets that are spread all over the corporation. But we can talk about that in a minute. But here's what I think happens. In our phone company, they got all addicted to process mapping. Well, mapping these archaic processes in the phone company, well, that was stupid. I mean, we covered conference rooms, ginormous walls with flowcharts of how terrible it all was. But did we actually go out and start to say, what specific things do we need to fix? And I come back to Duran all the time, vital few, trivial many.
Right.
And we were... the leadership guy he was just hot to trot on process and mapping everything. But I was very much interested in, what can we fix? So half the calls to the company were for repair. I wanted to work on repair. Well, no, we don't want you working on repair, So it's, I don't know what it is, but there seems to be a gap. And the other thing we did, too, I think, was had that whole model where you let the team choose the problem. And I think that's dumb. I think you should let the leadership team go, where's the pain? Let's go get some data. Let's go figure out how to fix that. And the other thing I see in healthcare is every couple of years they pick up performance improvement and they drop it and pick it up, put it down, pick it up and put it down. And the observation that I see is people go out there, and I see a lot of people I talk to in healthcare. They were trained by people who are manufacturing Six Sigma or manufacturing lean people. They are not healthcare lean people, right? And the amount of tools that you need in a healthcare environment are very small compared to what you might need if you wanted to go out and optimize a plant that makes carburetors, right? And so what happens is they have a disconnect about how to translate what they're being told or taught into how do I do that here. Right, and that's kind of the thing I've been chasing for a long time. And the other thing that happens, and I keep hearing this over and over again, is, we made this tremendous performance improvement in the emergency department. And throughput was really good for about 6 months, and then it fell off and went away.
Right.
Or we did it here, or we did it there. We improved lab turnaround times, and then it fell off. I essentially believe that nobody is doing the C in DMAIC control and putting in a control system to say, let's make this thing, let's weave it into the very fabric of how we do business, and make that the way we do things, and put some control charts on it so we make sure it stays. It was interesting. There was a recent article in the HBR where they talked about the great training robbery. And they said in the country, U.S., we spend $160 billion or something on training, and most of it's wasted because people go to class and learn all this stuff, and then they go back and keep doing what they've always done. and I see a lot of that as well. And so you wonder why things die. I think it's because we're not somehow transferring the love of improvement or something. I don't know where it is, but I keep trying to figure that out.
Yeah, I mean, I think one of the factors, I think you're right to bring up the point of, training people, identifying waste, that it's only so helpful. And if you don't allow people to go actually fix anything, if you don't prioritize improvements, if you don't sustain the improvements, a lot of that can be a waste. I think sometimes, and this is a problem going back to the Deming days, we're spending tons of money training the wrong people, that we want to send all our frontline staff and managers, and the executives don't learn anything about these new approaches, the management philosophy of Lean or management aspects of Six Sigma, and you have people running around using tools, and that can only take an organization so far. I'm sure that was part of the story of TQM failures, and that book from 25 years ago saying TQM usually failed because the executives didn't change. They didn't get involved.
Well, I have this theory because as I've looked at a lot of healthcare organizations, the new CEO comes in and either takes Lean and Six Sigma out or puts it in, mm-hmm. and they change about every 3 years. And so there's been a whole lot of study about how cultures adapt, and reject change, and over 50 years of study on this. And what they found is if the leadership team drives it, it invokes what's called the Stalinist paradox. Only half of the time will it work, right? And so I believe that the other thing they found is that if you want a culture to adopt a change, you need to get at least 4% making improvements. Right. And at that level, it'll stick. At about 20%, it'll reach a critical mass and take off. And it doesn't matter who the leadership team is. It is the informal leadership team inside that company, that hospital, whatever, that is going to sustain the change. I like to believe, I'd love to have great leaders, do this, but my observation is that doesn't happen.
Mm-hmm. Yeah. Well, and one other thing I want to come back to, you bring up the idea of solving problems that matter. You mentioned Duran. We hear the same thing from Taiichi Ono in the Toyota literature. He talks about solving the most pressing needs in an organization. John Shook at LEI talks about that a lot today. And I think there's a balance, and I'd be curious to hear your thoughts here, that there's something to be said for getting people participating. And getting people, if they work on something they choose, they're going to be enthusiastic about it. You get closer to that 20%. But at the same time, if there's some big, huge pressing need, like people are waiting hours and hours in the emergency room to see a doctor, or they're waiting for days to get a bed, like we really should prioritize something like that, I think.
Yeah, well, you would think so, So here's the bad news. Okay, I believe healthcare has been admiring the problem, and I call it admiring. All right, so according to Press-Ganey, who tracks all this junk, the length of stay in emergency departments is 4 hours, unchanged for a decade. Yeah, unchanged. One study in Minnesota found that never events, things that should never happen, essentially were unchanged for the last decade. Right. The big report in 1999 to Error is Human, the IOM came out and said, we kill 100,000 people a year unnecessarily, and it's probably about 5 times that, actually. But the problem is we haven't seen the progress, except in a few exemplar hotel systems around this country, right? And so most people are admiring the problem. And so how do we get on board? And I believe, Medicare is forcing changes through payment. That's one thing. I think we're seeing a starting shift from it used to be a physician-centric model where everything was designed around making the physician efficient, which is silly because when you make the patient efficient, the physician does lots more good stuff, right? Yeah. And so we're seeing a slow shift towards a patient-centric model in the exemplar hospitals and not so much in other places. And so it's this horrifically slow transformation. Right. And because half the hospitals are in some sort of financial problem, I believe that somebody offshore is going to figure out a model that will drive costs down, deliver great quality of service, and come in and just buy up hospitals, take them over, and teach them how to run. and I think they're going to force it down people's throat, and I think that will be an ugly day for healthcare, but I think it's coming.
Yeah, well, and you talk about these problems not getting solved. It's it would lead to one of two conclusions: that the problem can't be solved, or people just don't want to solve it. And like you said, there are exemplars that disprove the notion that these problems are unsolvable. So, that
or solvable.
Yeah, they are solvable. Yeah.
In 2004, Robert Wood Johnson Hospital out in New Jersey won the Baldrige Award. And in their emergency department, they set a goal. They said, you're going to see a nurse in 15 minutes, a doctor in 30 minutes, or your visit is free. Guess what? They didn't give away any money, or very little money, all right? And then the other thing that happened was, the school mom figured out that they could get their kid in and out of there because they would discharge patients in 38 minutes. Not 4 hours, 38 minutes, or admit them in 90 minutes. Now, what that did was everybody figured out I can go there and get my kid in and out, or whoever it is in and out, in a very timely fashion. And I was talking to some people from there a few years ago, and they said, we had to add another wing on the hospital because there was so much volume coming through the emergency department. Right. We needed a whole new wing to run to meet the need, right? So we didn't have to transport people to other hospitals. So this, that's lean. That is lean at warp speed, driving improvements, growing profitability. I mean, it's just amazing.
Well, and that's a far more positive, less dysfunctional approach than cost cutting, whether people are using Lean or Six Sigma or any of those approaches for cost cutting. I hear a lot of times people talk about Six Sigma, and again, this is not my area of expertise, but they talk about cost, and I say, wait a minute, I thought this was supposed to be a quality improvement methodology, and it's gotten hijacked or bastardized in some way. What are some of your thoughts? Any thoughts on that idea?
Well, my observation is every company, according to Duran, throws away 25 to 30% of their revenue fixing stuff that shouldn't be broken and trashing stuff that can't be fixed. And the same is true in healthcare. Yeah. We estimate there's out of the $2.9 trillion we spend on healthcare, that $1 trillion is for waste and rework. That's a lot. And $250 billion of that is for unnecessary tests and treatments. Right? That's overproduction. That's a plain old lean overproduction thing. Yep. Right? And so there's this huge opportunity. If there were estimates that said if we cut that by 20%, it would pay for Obamacare. If we cut it by 80%, it would clear the national debt. Wait, why aren't we on this? Yeah. And I believe healthcare, if they really just jumped on it, could make dramatic improvement in 18 to 24 months. And so, my observation is when you cut, when you reduce your defects, mistakes, errors, time to get things done, delay, defects, and deviation, I say those are the three silent killers of productivity and profitability. All of a sudden, a lot more money falls to the bottom line, because you cannot tell in a hospital if that patient is in a bed because we made a medical mistake and we're not getting paid for them, or they're just in a bed and we're being paid for them.
Yeah. Well,
you cannot tell.
I'm sorry?
You cannot tell which one they are.
Yeah. Well, and I think, there's a huge difference between, I think, a process improvement approach that eliminates waste, improves flow, which is sort of, it's different than efficiency. That leads to financial gain, as opposed to, the common playbook in healthcare before lean, without lean, has just been stupid cost cutting, laying people off, cutting services, hoping that if we fire a bunch of people, those who are left will somehow figure out how to get the job done. And I just don't see that as a good path to productivity, yet alone quality, safety, patient satisfaction.
Yeah, but we see that across the board, whether it's in healthcare or not. Yeah. Right? When times get bad, we just take out the axe. Yeah. As opposed to, to your point, what if we used lean to simplify and streamline so we were wicked fast? And the byproduct of being wicked fast is you don't have a chance to make a mistake, right? Because you never set the patient down.
Right.
My wife's aunt, she took her in and she fell and had to have a CAT scan. She had a CAT scan. They had a shift change, and after the shift change, the nurse came in and said, "Here, drink this contrast." My wife said, "Why are we doing that?" Yeah. And she said, well, she has to have a CAT scan. My wife said, no, she's had a CAT scan. We're not doing that again. Well, no, she hasn't. Yes, she has. Go check it out.
Yeah.
But without somebody running the game there's been another CAT scan, which had been ridiculous.
Yeah.
So that's the great thing. So if we use Lean to simplify and streamline, and then we use Six Sigma to optimize, to find the things you can't find necessarily through a Lean approach, things that are more that invisible low-hanging fruit, then we can start to really chop away at that cost, and maybe we could cut costs by 25, 30%. And what would that do for your bottom line? Right. It's not just random axe cutting, right? We're finding exactly where to fix stuff.
Yeah, and so let's talk a little bit more about Lean and Six Sigma and combining methodologies. I mean, I think the way you articulated that is something I would agree with, that we can use Lean to improve flow, improve processes, engage people. There are some problems that require deeper statistical analysis, and I don't deny the usefulness of Six Sigma or statistics. The one thing, though, that I disagree with, and Michael George, who you mentioned earlier, the cover of his book, and in the book talked about Lean, speed, and Six Sigma quality. In your books, Lean Six Sigma for Hospitals, you say the same thing, that Lean will reduce these 6 types of waste, and Six Sigma will help you reduce defects. And I'm just curious your perspective on that, because the way I would see it is that Lean and the Toyota production system is about flow and quality. Like you said, they go hand in hand. Lean has a lot of approaches that would help reduce defects. What can you kind of tell me the story behind why you say that in your book?
Sure. Well, one of the things is, I think sometimes people get their undies in a bunch about the rigor of either a Lean or a Six Sigma, and I'm less of a purist and more of a realist, right? So how do we get people on board with things? So in healthcare, it's not like a manufacturing factory floor, right? It is clinicians working with patients, and their big problem is the gaps between the clinician being with the patient and the next step in their process. Right. So one of the great things about Lean is if you collapse those delays,
right,
then you don't have a chance to make a mistake. You don't have a chance to do the test over again. You don't have a chance to miss a step in your process. And so Lean, as a result of removing all those other 6 wastes, guess what? You get phenomenal improvements in quality. No doubt about it. But you're not going at it directly. My observation is you're going at it indirectly.
But I think you're doing both with Lean. I mean, there is that effect you said of better flow leads to better quality, but there are also the methodologies around root cause problem solving and Lean problem solving that are directly used to address many quality problems and sources of defects, which then lead to improved flow. Right.
And, even root cause analysis is like in the middle of Six Sigma. So how do we separate those 2 apart? And what I'm trying to do is, you got to remember, in healthcare, these people aren't, long-term dipped in Lean and Six Sigma. Most of them may have heard of it, may not have heard of it, right? Or they've been dipped in process improvement. Or the Institute for Healthcare Improvement, which just met last week. I was there at the conference. They have improvement advisor training, which is sort of their take on Lean and Six Sigma training. And so how do we pair those out? I'm not trying to make them one right and one wrong. What I'm trying to do is offer to the people that I'm talking to what tool is vital for you to use, right? So for me in healthcare, if you want to reduce your cycle time and reduce defects, get the value stream map and a spaghetti diagram and go to work. Right? And here's the deal. Every year I go to this conference. I've been going to the IHI, the Health Improvement Conference, for 10 years, 11, 12 years. And every year I look through all the poster presentations. And guess what? This year there were no value stream maps. There were no spaghetti diagrams. There were a few flow charts, And you know what the vast majority of them had as charts? They had bar charts and line charts. Like 3/4 of all the charts are bar, line, and pie charts drawn in Microsoft Excel. Mm-hmm. There's no control charts. There's no Pareto charts. I mean, not quite. But a very low proportion. And it was very funny. Don Berwick, who was the head of the IHI back in 2006 when I saw him, said, "Hey, I want you guys to pledge allegiance to science and evidence." Mm-hmm. And then last year at the closing keynote, I heard him kind of sadly, just kind of with dismay go, mm-hmm. "I've been asking you guys for 10 friggin' years to pay attention to science and evidence, and I don't see it." Right? So I'm going to go back to how do we simple this up enough that our audience can grab hold of it and run with it. And I can tell you, when I go in and train a group of nurses or something, and I get them to do a value stream map or get them to do a spaghetti diagram, they figure out how to cut travel time in their nursing unit in like an hour.
Right.
And if they cut all their travel time, guess what? They're going to spend more time with patients. They spend more time with patients, they're going to have better outcomes and better patient satisfaction, get paid more money. It's so simple, right? But one of my observations is in the lean world, sometimes people get really hung up on what are the clinicians doing in that little box where they're doing stuff. That's irrelevant in the grand scope of how much cycle time and mistakes can happen. That has little to do with reality. It's all that delay and all that movement and transportation. That's where we're killing people. And so, the estimate is there's like 3 747s a day of passengers that crash and burn because of some sort of medical mistake, and that's a day.
Right.
So, I don't disagree with you that lean can have dramatic improvements in quality. Six Sigma is going to go after it directly, but I think you should do that after you've done lean.
Well, I would agree with you there. I think, and I've heard that feedback from a lot of hospitals out there who were introduced to Six Sigma in the late '90s by GE, and a lot of people saying, in hindsight, we should have used lean first and taught that to everybody and started creating that culture, and then use Six Sigma as appropriate, and have a few specialists who can go and roll up their sleeves and solve more complicated problems with more complicated methods when appropriate.
I always say there's 3 types of problems. There's simple problems, and if they're simple, go fix them.
Right.
Right. At the high end, there are complicated problems which might need more exotic tools.
Sure.
But the vast majority of problems are uncomplicated problems, but they might need some data analysis. They might need some mapping of the process. But it's not going to take forever, right? And we can solve gazillions of those. And then I also find that some of those complicated problems, you don't need DOE, you don't need exotic stuff, right? Sometimes complicated problems are just a constellation of uncomplicated problems. And as you pull those apart, you slowly discover that, that complicated problem is gone.
Sure.
And so that's been kind of my approach. People accuse me of trying to dumb down Lean and Six Sigma, and I'm not. I'm trying to simple it up. I'm trying to simple it up to the point where I can get everybody to go, "Oh, I can do that."
Yeah, right. Well,
even the people that walk in the room go, "I don't know anything about math and statistics," and they walk in the room and go, and they're starting to analyze their own data or draw their own value stream maps. I am thrilled with that, right? I'm just thrilled with that.
Well, so I wanted to, let's touch on that and dive a little deeper, because I think one of the points that you make really well in your book is about not going overboard with Six Sigma. I think you mentioned control charts, and when I worked at General Motors 20 years ago, control charts were being done by the UAW assembly workers who barely had a high school education. It's just facts are facts, and control charts are not that complicated. I don't think simplifying means dumbing down at all. But can you share some examples of maybe some other examples where people go overboard and some ways that keep it simple to the appropriate use of Six Sigma tools, the appropriate level of complexity?
Sure. Well, you mentioned GE. I had a friend who actually was a trainer for GE, and GE Healthcare, and she said, we had 3 days of DOE training in there, and she said, why were we doing that?
Right.
Because they're never going to use that unless you're in medical research or something like that, right? And so one of the things that I observe is we try and teach people things they don't need to solve problems they don't have. So in healthcare, you need a much smaller toolkit than you need to do things on a factory floor. And I think the American Society for Quality got lost a little bit here because, they were Deming Duran, they were manufacturing folk. And, even Deming, I saw him many years ago, and he said, I have no idea why anybody put the word total on total quality management. No, vital few, trivial many. Right, but somehow it got that thing. And through total quality management or Six Sigma, people get this, we have to go wall-to-wall, floor-to-ceiling, train a billion belts, and tackle everything on the planet. And all that does is burn time and energy that could be spent on important things. And so very often I see that people are trying to do it everywhere rather than in the vital few places. Or sometimes people, because I have the QI macros, people send me their improvement projects, and I get to see some control charts and Pareto charts, but sometimes they're really disconnected. They don't know how to connect the dots. And sometimes I find that people have taken an improvement that they did through gut feel and trial and error, and then they try and retrofit data to it so that they can get their green belt or black belt. It's like, whoa, wait, let your data lead you. You will be stunned by what it'll do for you. So, I think number one, don't try and teach them everything. I call them the Magnificent Seven tools, but, value stream mapping and spaghetti diagramming are those kinds of things. The secret sauce to finding the low-hanging fruit are pivot tables. And then you need a control chart, Pareto chart, histogram, fishbone diagram, countermeasures, and some action plans. You don't need a gazillion tools. Do I need a project charter? Not if you got data that says you need to go do something, because it shouldn't take that long, right? Most of my projects I got done in an afternoon with people. I helped one local hospital save $5 million in denied insurance claims in an afternoon, right? And so they just implemented the changes in the process the next Monday morning. So these are the kinds of things, I think we get confused. Six Sigma project should take 14 weeks. No, it should take as long as it takes. The solution is easy. The implementation may take longer, depending on what you need to do that. But anyway, that was a long rant about that. But
that's all right.
I think the Six Sigma world has done a disservice by overcomplicating what we're trying to do and what problems we're trying to solve.
And I think there's that classic Six Sigma answer. Lean people say it too. If you ask, well, how long is a project supposed to take? I would say it depends. I think it depends on which of those three types of problems. It depends on a number of factors as opposed to always having a hard set rule, right?
Right.
When I was at Honeywell, my last manufacturing company, I went through, if Honeywell was interesting, they did Lean and Six Sigma, and they claimed it was an integrated methodology, but you either went down a Six Sigma black belt track or a Lean black belt track. It was very siloed. And I would see, people, colleagues of mine, going down the Six Sigma track. They were given an important business problem. The department wasn't keeping up with customer demand. They were shorting. They were late to the customer. Inventory was too low, and I'd hear my colleague, at her desk talking about doing the multiple regression analysis, and I would talk to her, and it was what you described. She said, "Well, to get certified, I have to use all of these X number of tools." I'm like, "Well, Rome is burning, and this business is really suffering." I call it 5S'ing the deck chairs on the Titanic. I'm mixing methodologies and metaphors here, but I saw some of that happening, back in the manufacturing world, which often just made me shake my head. Again, it doesn't mean there's anything wrong with these methods or tools, but I think sometimes the guidance people are given or not given.
Well, the last 25 years we've been teaching Lean and Six Sigma. And in the Six Sigma world, for sure, we're still teaching it the same way we did 25 years ago. Well, why is that? Maybe there's a better, faster way to teach that. You know, maybe there's an accelerated method. Maybe we can tailor this to the right thing. But I think it's become one of those things where people are chasing a belt so they can add it to their resume. You know, we've trained a gazillion belts. Why aren't things any better?
Right.
I wait. You know, we've done that, but obviously it's not translating into action, well, and that's a gap.
Yeah, I mean, I saw at Honeywell they bragged about how many people had been certified as Six Sigma green belts, and there was a wall full of certificates. And I thought, well, that's not the meaningful metric. The number of certificates on the wall. It was, you know, if it was 500 certifications, how many projects had been done? About 502. I mean, it was just not translating into anything approaching ongoing continuous improvement. Yeah, well, you know, that's why I call it a money belt. You know, I have a little ribbon that I wear at these conferences that says money belt on them. People go, and it's green. It says, what? They say, what's that for? And I said, well, there's green belts and black belts and people who can actually save money using the tools of quality. That's a money belt, right? I'm $1 million money belt. I can save money, right? But so many people, I'm just floored, you know, that people aren't able to find ways to radically improve the business they're in. Right. The other thing, too, is I think humans, by their very nature, you know, neuroplasticity says once you've done something for a while, you hardwire it. So you just do it that way forever. And so when we try and implement a change, it takes an enormous amount of energy to sustain the new change to the level where the brain unwires the old learning and wires in the new learning. Right. And it takes a long time, and I think people underestimate that, I believe. So as we wrap up here, let's talk a little bit about your book in the second edition, Lean Six Sigma for Hospitals. Can you tell a little bit of the story behind the book? Why write a book, and what's new in the second edition? Sure. Well, back in 1999 when To Err Is Human came out, and the Joint Commission told all the hospitals, if you want to be an accredited hospital, thou shalt draw control charts. There was some listserv out there where nurses would ask, how do I draw a control chart? And a half a dozen nurses would respond and say, go buy a copy of the QI macros. Because I'd launched them in 97, and they were creeping into some sort of product shape by 99. But then because of that, then I got called in to work with various hospitals across the nation. So I've worked with, the Veterans Administration and HCA and people all from coast to coast, north to south. And so as I learned more about what was going on in healthcare and how to help these folks, and I do a one-day Lean Six Sigma healthcare training. I mean, that's yellow belt. If you learn all of that and just apply it, you'll be stunned. And then I force them all to bring their own data and their own projects to work on. And so we get to results pretty fast. Mm-hmm. And so out of that, I started to notice, well, what are the sort of things we need to work on? And so the first edition of the book started to talk about what I was seeing and how to use Lean and Six Sigma in a hospital environment. And you could do it in a doctor's office, doesn't matter. But really hospitals, because that was the big area. And then since then, the second edition, I think there's a whole new movement afoot, and that movement is zero harm. Right? Zero harm. And somebody said to me the other day, well, isn't that in the Hippocratic Oath? And I said, well, if that's true, then why does the IHI say that one patient out of every two suffers some sort of preventable harm? Well, as a quick aside, the phrase "first do no harm" is actually not in the Hippocratic Oath. It's just a different historical healthcare expression. Right. Okay. So good. Thanks. But they bring that up, and I said, well, sure, that'd be nice if the data showed it was working, but it's not. And so there's a number of hospitals, most notably Memorial Hermann down in Houston, that is adopting high reliability, becoming a high reliability organization, or an HRO. And so they're modeling things like Disney theme parks and nuclear power plants where you can't fail. Right.
That's not a good thing. And so they're applying those things. And their definition of a high reliability organization is Lean, Six Sigma, and the missing link, change management.
Right.
And change management is how do we weave the results of these things into our hospitals and make sure that it sticks. And so that's what they're doing. And, you know, they've done things where they have awards for people who've gone 12, 24 months, 36 months without a hospital-acquired infection, without surgical complication, without a blood transfusion problem, right? And so they're tracking that. And South Carolina as well, their whole state, they have 168 hospitals that have received a 12-month or better zero harm award. And so I think the new future is in zero harm.
Right.
And so, and the other thing, huh?
It needs to be.
Yeah. Well, if we do that, we're going to save $1 trillion and be able to provide a lot more care to a lot more people. And then the other thing that has happened is we're finally seeing the payoff of some of these places like Virginia Mason, who just took TPS and ran with it and really made some dramatic improvements. You know, I love the story in the book, Transforming Healthcare. But they brought in the Japanese counselor, and the Japanese counselor looked at the map of the hospital and said, "What are these rooms?" And they said, "Well, those are waiting rooms." He said, "Who waits there?" "Patients," they said. And he said, "How long do they wait there?" 45 minutes to an hour. And he says, "Aren't you ashamed? Aren't you ashamed?"
Yeah.
And so Virginia Mason, when they redid their clinic, there is no wait room. You come in, you swipe your card, it gives you a rooming card, you go into the room and you see a doctor or a nurse in about under 7 minutes or something like that. Very different model. So
yeah,
these are the things that I'm seeing is there's movement afoot. Now, the IHI has been meeting for 28 years. You'd think we'd be further than we are. Right? You'd think we'd be further than we are.
I mean, you can ask the same question, why aren't you ashamed of all the harm that takes place? But people aren't ashamed of something they consider normal or unsolvable, or that's just the way it is. I think that's part of the battle.
I think they hate that, but they don't know what to do about it. And I think our job in Lean and Six Sigma is to help them understand how do we solve the unsolvable problem, and then figure that stuff out. You know, I talked to one woman. She was using our Pareto chart, but she did some analysis on patient falls, and it turns out most of the patient falls in their hospital occurred in orthopedic wards after surgery, men between the ages of 20 and 40. Well, with that kind of data, guess what? You know, we can actively do things to monitor the 20 to 40-year-old guy who comes in and gets a knee fixed or something like that. So, you know, it's not spread. I always say, you know, problems aren't spread all over like butter on bread. They're more like mold on bread. They cluster in places. If we could just go figure out where they're clustering and fix those, then we're not going to, you know, cause all these problems. And so I think if we can help healthcare see the opportunity and grab onto it and make it simple enough that they can go, oh, I can get people together for 2 hours to do a value stream map and figure out how we're going to change this organization in flight, right? Because you can't shut down a nursing unit to do a 7-day Kaizen event. You have to do it in flight. So I think that's our opportunity, and that's what I keep trying to do. That's what I was trying to do with the book. And, you know, people come up to me and they say, you know, we were dipped in the traditional Lean and Six Sigma thing, and we read your book, and now we understand why we didn't understand it.
Yeah.
You know, now we know what to do differently. So if nothing else, I hope that's done some good.
And what's new in the second edition?
Well, in addition, I talk more about high reliability organizations, and I also have a variety of case studies because our exemplars, like Virginia Mason, Herman Memorial, Mayo Clinic, obviously, has always been doing things around innovation. Cleveland Clinic, the other things that are coming out where the CEO has been in place for a decade, and they're pushing toward different models of care. right? Different ways of paying for things, like Geisinger in Pennsylvania. They have a fixed price if you're going to have a knee replacement, and so it doesn't matter what goes on. It's a flat fee, and because they do them at a flat fee, they get very good at it. And so there's different models. Medical tourism within the United States is going to be a huge thing, and companies like Walmart and stuff say, well, you have to go to Geisinger to get your treatment because, number one, it's a fixed price, and they're cheap, and they're better than everybody else. So we're seeing the payoff start to come through, but I think it's just slower than it needs to be.
Yeah. Well, I hope people will go and check it out. Lean Six Sigma for Hospitals, 2nd edition. Jay, where can people find more information about you, your books, QI macros, other stuff online? Where should they go?
Yeah, if you go to our website, QImacros.com, that's QIMACROS.com, you can find out more about that. I have a free Lean Six Sigma Yellow Belt training with healthcare examples. And that address is lssyb.com for Lean Six Sigma Yellowbelt.com. And we just put up some new healthcare data guide examples. So we have lots of data in the software to help you do and understand what kind of chart do I need to do with this kind of thing. And we also have a lot of good control chart wizard tools that will help you pick charts. You know, I don't believe people should know formulas. I don't believe they should know a lot of this nonsense. The software will help you pick the right chart, the right analysis. And so if you do that, then it makes it simple for people to stop learning all the nonsense and get on with solving real problems. And if anybody wants to buy the book, it's cheaper on Amazon.
Okay.
I can guarantee you.
Yeah.
I mean, I buy them from there because it's cheaper than buying them from my publisher. How's that? Ludicrous.
Well, value and flow and everything in publishing, that's a whole different discussion. Every author I've talked to kind of grumbles about how set in their ways publishing is. Reminds us of other industries, but it's not just a healthcare problem. Being set in your ways.
In the phone company, I always described it as 100 years of tradition uninterrupted by progress. And we can say the same thing in healthcare, right? Atul Gawande, who's written a lot of good books on this, like the Checklist Manifesto, he said, we're still using the same model we used 100 years ago. Wake up, right? So I think there are lots of really good opportunities out there. We just need people who want to drive forward and make that happen. And it can be somebody, I think, who's an informal leader inside the organization, and they can go slay dragons, or they can wait for the leadership team to anoint them with the task of doing it. But everybody's busy. Everybody's too busy, I think.
Says that, yeah. And it comes back to the question, we're too busy to improve, or are you too busy not to improve, or not improving is part of why they're so busy? But that's the
one of the guys I know, Rory Vaden, he has a concept called ROTI, which stands for Return on Time Invested. Mm-hmm. So if you could take and spend 2 hours a week, I ask everybody, spend 2 hours a week making some sort of improvement in your workspace, even if you have to steal 2 hours. If that 2 hours saves you an hour or two the next week, forever, at some point the return on and time invested is going to be massive.
Yeah.
Right? So you need to put in, and everybody can squeeze out an hour here or there. They just can, right? So I think there's people say I'm too busy. Well, no, you just haven't marked an hour, right? Yeah. So it does take a little time management to go get that done.
Yeah. All right. Well, thank you for joining us today, Jay. Our guest again has been Jay Arthur. The book is Lean Six Sigma for Hospitals. Thanks so much for joining us and sharing some of your stories and experiences and perspectives today. Really appreciate it.
Hey, thanks very much for having me on. Let me rant about one of my prime things in life. I just turned 65. I got my Medicare card. I need health care to be better than it is.
Right. We all do, different reasons and different ages, and Good luck with all that. Hope you have a healthy and happy New Year.
Yeah, back at ya.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.